So picture this. You just left the clinic after getting, like, a cosmetic microinjection.
Right, maybe a dermal filler in your lips or some sort of skin booster.
Exactly. And you look in the mirror, and the aesthetic result is exactly what you wanted. You look great. But biologically speaking, right now, your skin's microscopic barrier has just been breached in literally dozens of different places.
Yeah, it's completely compromised.
Right. And what you do in the next 48 hours is the literal difference between, flawless, invisible healing and a stubborn, completely hidden infection.
It's so true. I mean, we so often focus exclusively on the visual, the aesthetic outcome of these procedures. But biologically, the second those needles withdraw, the tissue is in this state of high alert cellular triage.
Because it's trauma, right?
Exactly. A cosmetic procedure is fundamentally controlled trauma.
Which is why today we are doing a deep dive into that exact 48-hour critical window following that trauma.
It's such a crucial window.
It really is. We're pulling from a pretty massive stack of dermatological wound healing studies, clinical aesthetic guidelines, and some incredibly fascinating research on mucosal barrier function.
Yeah, the mucosal data is eye-opening.
Because our mission today is to figure out the exact post-procedure cleansing and barrier emollient protocols required to protect those microinjection puncture points, especially in the fragile skin of the lips.
Right, because the underlying biology of the lips basically dictates why standard facial skincare protocols just fail completely when you apply them to mucosal tissue.
You just aren't built the same way at all.
Not at all. I mean, the lips are part of the body's barrier immune system. They're designed to interface with the outside world, yet their architectural defense is remarkably weak.
Yeah, I mean, looking at the dermatological text we have, the structural difference between the skin on your cheek and the skin on your lips is staggering.
It really is night and day.
Like the stratum corneum, which is, that outermost dead layer of cells that protects your living skin. It's highly robust on the face. It's about, 15 to 20 cell layers thick.
Right, it's a stacked brick wall.
Exactly. But the lips, that outer layer, is only 3 to 5 cell layers thick.
And that structural vulnerability is compounded by a chemical deficit, too.
Oh, right, the sebum.
Yeah, standard skin is packed with sebaceous glands that produce sebum. And sebum is this complex mixture of lipids like triglycerides, wax esters, squalene that naturally coats the skin.
It's like a built-in lotion.
Basically, yeah. It acts as an endogenous emollient to keep the tissue pliable, and it forms a slightly acidic mantle that deters bacterial overgrowth. But the lips, they have absolutely zero sebaceous glands.
Zero. Meaning they produce absolutely no natural oil, no built-in weatherproofing. And they only have a 3-layer defense to begin with.
Which is terrifying when you think about it.
It is. It's essentially like building a house with a paper-thin roof and absolutely no weatherproofing, like in a rainstorm.
That's a great way to put it.
So when a needle punctures this specific tissue, what actually happens to that barrier? Like during a hyaluronic acid filler treatment?
Well, the needle physically tears right through that already precarious 3 to 5 cell layer.
It just bypasses everything.
Totally. The physical puncture creates this microscopic highway bypassing the barrier entirely. It exposes the highly vascular underlying tissue and the bloodstream directly to the outside environment.
And to all the stuff living on our skin.
Exactly. To the resident flora. I mean, we all carry bacteria like staph and strep on our faces constantly.
Which usually isn't a problem, right?
Right. An intact barrier keeps them completely harmless.
Right.
But a breached barrier, that invites them into a warm, nutrient-rich, deep tissue environment.
And we touch our mouths all day long. I mean, we talk, we eat, we drink.
We constantly introduce new bacteria to that area.
So that physical puncture leads directly to our next major issue, which is what manages to sneak inside those micro wounds before they can actually close up.
And the timeline of what happens inside those wounds is exactly where the clinical complications start to emerge.
Right. Break down the early timeline for us.
So in the initial 24 to 48 hours, the reaction is almost entirely mechanical. The immune system responds to the physical tearing of the tissue.
That's the swelling, right?
Yeah, you see hyperuremia, which is this massive influx of blood rushing to the local vessels to deliver repair cells. That causes the standard redness, the tenderness, and the swelling.
Which everyone expects, they go home and put some ice on it.
Right, but the clinical texts outline a much more dangerous, completely invisible threat that develops if those resident bacteria manage to slip inside the puncture tracks.
This is the biofilm part, which blew my mind.
It's a huge issue in aesthetics right now because when staph or strep bacteria enter a wound that contains a foreign material like a newly injected hyaluronic acid filler, they behave completely differently than they do on the surface.
They change their behavior.
Yeah, they attach themselves to the filler material and undergo a phenotypic shift to create a biofilm.
And looking at the microbiology studies, they describe a biofilm not just as like a clump of bacteria, but as a highly organized bacterial coral reef.
So that's the perfect analogy.
Right. They secrete this polymeric matrix, which is essentially a thick physical slime that encases the whole colony. It's basically a microscopic bunker.
A bunker that physically prevents host immune cells and antimicrobial agents from reaching the bacteria inside. And the clinical data on this is highly alarming.
Oh, I know what stat you're going to say.
Once bacteria are entrenched inside a biofilm, eradicating them can require up to 32 times the standard concentration of antibiotics compared to just free-floating bacteria.
Wait, 32 times the normal amount of antibiotics?
Up to 32 times, yes.
That is insane. If it's that hard to treat, why do clinics just tell you to keep it clean? Like, what does clean even mean in this context?
Well, that's exactly the problem. The traditional definitions of clean are actually shifting right now because telling someone to just keep it clean is vastly insufficient when you're trying to prevent a 32x antibiotic-resistant bunker from forming inside a 3-cell thick lip.
So what were they doing before?
Historically, the protocol was to use a harsh chemical antiseptic like chlorhexidine or heavy alcohol to basically wipe out all microbial life on the skin before and after a procedure.
Right, which sounds logical until you read what that actually does to the tissue. I found a massive red flag in the surgical prep guidelines regarding chlorhexidine.
Oh, yeah, it's gnarly.
It can be highly toxic to cartilage, and if it accidentally migrates near mucosal areas like the eyes, it carries a severe risk of keratitis.
Which is chemical inflammation and severe damage to the cornea.
Yeah, so pouring a chemical that literally causes tissue damage over a fresh, fragile lip puncture just seems totally counterproductive.
It actively delays healing because if you flood a microwound with the cytotoxic chemical, you are killing the bacteria, sure, but you're also killing the fibroblasts and keratinocytes.
The exact cells you need.
Exactly, the very cells your body is trying to use to repair the puncture, so you create a sterile but highly damaged environment.
Okay, so to answer my own question about what clean means now, we really have to look at how medical protocols have moved away from those harsh chemicals.
Right, toward cleansers that actually mimic human biology.
Because we need something lethal to bacteria, capable of dismantling that biofilm matrix, but completely harmless to human tissue. And the texts heavily focus on this molecule called hypochlorous acid, or HOCl.
Yeah, HOCl is incredible. It's a naturally occurring weak acid produced by human neutrophils, which are a type of white blood cell.
Okay, so our bodies make this naturally.
Exactly. When your innate immune system detects an invading pathogen, the neutrophils basically engulf it and trigger what's called an oxidative burst. They manufacture hypochlorous acid internally to literally tear apart the cell walls of the bacteria from the inside out.
That is so cool. So the body just manufactures its own highly calibrated bleach.
Basically, yeah. And the huge breakthrough in aesthetics is that scientists have figured out how to synthesize and stabilize this exact molecule in a bottle for topical use.
So you can just spray it on.
Right. And the synthesized version is pH neutral, which is vital because it won't sting or burn the raw punctured tissue.
Oh, that's a relief for anyone who just got lip filler.
Definitely. It's powerfully antimicrobial, it acts as an anti-inflammatory, and crucially, the mechanism of HOCl physically disrupts the polymeric matrix of biofilms.
It tears the roof off the bunker.
Exactly. But because the molecule is bioidentical to what your immune system makes anyway, it doesn't trigger any defensive inflammation or cell death in the surrounding human tissue.
Okay, so a practical question here. If HOCl is literally what our white blood cells make,
Yeah.
by spraying it on a puncture wound, are we basically tricking the skin into thinking the immune system is already on site?
Yes. You are completely flooding the zone with the exact defensive molecule the immune system would eventually send, but delivering it instantly from the outside before the biofilm even has a chance to form.
Wow.
The medical literature actually refers to this as utilizing an inorganic armamentarium of innate immunity.
That is a very fancy way of saying we borrowed the body's own weapon.
Pretty much. Products like Lumion Miracle Mist use this, and you can spray it liberally on days 1 through 3 post-procedure. It massively reduces the bioburden safely.
Now, I did notice the clinical wound care guidelines also bring up a second alternative to the harsh chemicals, something called octinidyl dihydrochloride, or OCT.
Yes, OCT is another powerful option. It destroys biofilms effectively, and it has an excellent biocompatibility index for superficial swabbing on mucous membranes.
But, and this is a huge but, there is a terrifying clinical warning attached to it in the texts.
There is. The strict warning is that it must never be injected or used under pressure in deep tissues or puncture tracts.
What happens if it does get in there?
If OCT gets trapped in the subcutaneous tissue and cannot drain freely, it induces severe tissue edema, so massive fluid swelling and necrosis.
Necrosis, which is actual localized death of the tissue cells.
Yes.
Which makes it seem completely inappropriate for a regular consumer to be messing around with at home.
Mm.
Like if you have dozens of fresh, open puncture tracts in your lips, you definitely don't want to risk a chemical seeping in and killing the tissue.
No, you really don't. Sticking to a gentle, bioidentical HOCl spray seems like the only foolproof route for a patient managing their own care in those first 48 hours.
All right, so once the puncture points are safely cleansed and the biofilm threat is neutralized, we run into the next problem.
Rebuilding the wall.
Exactly. The physical barrier is still broken. The paper-thin roof still has holes in it. And as we established, there is no endogenous sebum to help seal it.
Right, which leads us into the barrier repair protocols. And specifically, the massive difference between using an occlusive and using an emollient.
Because I think most people just grab whatever thick petroleum jelly they have lying around when their lips are dry and swollen, right?
Oh, absolutely. They assume that thick layer is the best way to protect them. But pure petrolatum is a classic occlusive.
And what does an occlusive actually do?
Well, an occlusive does not absorb into the skin. Its entire function is just to sit on the surface and form an impermeable physical seal to stop transepidermal water loss.
Meaning the evaporation of moisture from inside the tissue.
Exactly.
But wait, if we go back to the anatomy of the lip, it produces no moisture or oil of its own. So if you have a dehydrated, swollen lip that has just been repeatedly punctured and you smear a pure occlusive over it, you aren't actually adding any moisture.
No, you are just sealing in the dehydration.
So using just an occlusive is like throwing a tarp over a dry garden.
That's exactly it. To actually repair the tissue, you must introduce an emollient.
And an emollient is like watering the soil first.
Right. Emollients are lipid-based substances like ceramides, hemp seed oil, or shea butter that physically sink into the spaces between the skin cells to replace that missing sebum.
They actually penetrate.
Yes. They soften the tissue, provide flexibility, and deliver the moisture necessary for cellular repair.
And looking at the dermatological post-act recovery studies, there is a specific hero ingredient they rely on to accelerate this repair phase: sucralfate.
Sucralfate is amazing. It's heavily utilized in specialized post-dermatological act products, such as the Avene Sucralfate plus post-act repair emulsion.
And the mechanism is wild.
It really is. So sucralfate is an aluminum salt of sucrose sulfate, and it carries a strong negative electrostatic charge.
And damaged tissue, or the proteins exposed inside a fresh microwound, carry a positive charge.
Precisely. So due to that charge differential, sucralfate electrostatically binds directly to the damaged cells.
It's like a microscopic magnetic patch over the puncture holes.
Exactly, but it goes beyond just being a physical shield. Biologically, sucralfate actually signals and induces the proliferation of fibroblasts and keratinocytes.
Meaning it's planting the seeds for new growth.
That's exactly what it's doing. By applying sucralfate, you are actively commanding the local tissue to speed up the manufacturing of replacement cells. It basically accelerates the closure of the microwounds.
That's so smart.
And in high-end post-act emulsions, sucralfate is intentionally paired with copper sulfate and zinc sulfate, which actively limit bacterial replication.
So the synergy of the entire protocol is just incredibly precise. You use the HOCl spray to safely dismantle the biofilms. Then you apply a specialized post-act emulsion where the sucralfate magnetically patches the microscopic holes and triggers cellular growth. The emollients replace the missing sebum, and the copper and zinc act as a secondary guard against the bacteria.
You are basically constructing a highly optimized artificial healing environment to compensate for the lip's biological deficits.
But of course, rebuilding the barrier is difficult enough. The mucosal skin of the lips faces a uniquely relentless challenge that the rest of your skin just doesn't.
Right, you eat and drink through it.
Yeah, you don't eat your meals through your forehead.
Exactly. The mechanical stress of talking, chewing, and stretching is constant. Plus, the mucosal barrier is bathed in saliva, which contains digestive enzymes.
And it comes into direct contact with the chemical composition of literally everything you consume.
Which brings up a really fascinating insight from the sources regarding food chemistry and mucosal barriers.
Oh, the emulsifier study.
Yes. Emulsifiers are ubiquitous additives in processed foods, everything from ice cream to non-dairy milk and canned soups. The study focused heavily on carboxymethylcellulose, or CMC, and polysorbate 80, known as tween 80.
And they use these in food to prevent separation, right?
Yeah.
Give it a smooth, creamy mouthfeel.
Right. But the researchers discovered that when these specific chemicals are ingested, they physically alter the structural lattice of intestinal mucus.
Which is supposed to be this thick, viscous net that keeps gut bacteria safely away from the delicate cellular lining.
Exactly. But acute exposure to CMC and tween 80 actually decreases the pore size in the mucus net.
Now, you'd think a tighter pore size would slow bacteria down.
You would think so, but counterintuitively, the altered physical structure changed the viscosity in a way that allowed microbes to swim through the mucus significantly faster.
Wait, really? They sped up.
Yes, in the healthy models, the mucus kept the microbes suspended about 25 micrometers away from the epithelial tissue. But after exposure to the emulsifiers, the microbes were able to encroach to within 10 micrometers of the tissue,
They bypassed the defense and got more than twice as close to the vulnerable cells.
which triggers severe local inflammation.
Okay, let me ask a connective question here, though. Since the lips are the gateway to the digestive tract, does this mean the chemicals in our processed foods could actually be aggravating mucosal barriers right at the source?
It's a great question. While the studies focus on the gut, the underlying biology shows exactly how reactive and vulnerable mucosal barriers are to daily chemicals.
So eating a bowl of ice cream with polysorbate 80 could inflame my fresh lip filler. Am I supposed to just fast for a week?
Well, no, the clinical guidelines aren't mandating a strict dietary fast, but the biological parallel perfectly reinforces why post-injection lip care must be obsessively pure.
Hypoallergenic, fragrance-free, meticulously formulated.
Exactly. The tissue is already compromised by the needle trauma and the swelling. You do not want to introduce heavily fragranced, chemically complex, or synthetic cosmetics that could further inflame the barrier or provide a substrate for bacteria.
Which is why the aftercare rules are so strict, like no non-sterile makeup for at least 4 hours.
Though a full 24 hours is highly recommended.
Right. No aggressively touching or rubbing the tissue, which would just reopen the micro wounds, and absolutely avoiding excessive heat like saunas or intense cardio for 48 hours.
Because heat massively exacerbates the hyperemia and swelling, it really requires an obsessive level of purity until those 3 to 5 cell layers have fully reknitted themselves.
Taking a step back, looking at the sum of these sources, it fundamentally changes how you view a simple cosmetic injection.
It really does. We aren't just plumping the skin, we are navigating a massive biological vulnerability.
The mucosal skin of the lips just lacks the basic armor of the rest of the face. It's incredibly thin and produces zero natural oils. And once a needle physically breaches it, the clock starts ticking on those resident bacteria attempting to build highly resistant biofilms.
But the medical response has evolved so beautifully. We moved away from pouring toxic tissue-killing chemicals onto the wound toward utilizing advanced biomimicking cleansers like HOCl.
Safely neutralizing the threat by deploying the exact same molecule our own white blood cells use.
And instead of just suffocating the tissue with petroleum jelly, we use targeted emollients with sucralfate to actively repair the skin.
It is a complete shift away from synthetic dominance toward biological synergy.
We're finally supporting the immune system rather than carpet bombing it.
Which leaves you with this to think about. If our own white blood cells produce hypochlorous acid to fight pathogens, and we can now bottle that exact molecule to heal our skin from the outside in, how long until all our cosmetics stop relying on synthetic chemicals and just start mimicking the genius of the human immune system?
That's a profound thought to end on.
Thank you so much for joining us for this deep dive into the clinical sources. Take care of your barrier, and we'll catch you on the next deep dive.